Welcome. This month's MEC Minute is on heart failure. We're doing this this month at the request of several of our providers who asked for an update on heart failure, including a review of current treatment methods for us in the field. So let's start with a definition. What is heart failure? Heart failure is the inability of the heart to produce adequate cardiac output to meet the metabolic needs of the body. So when you think about heart failure, keep in mind that cardiac output is the product of pulse rate times the volume of blood or stroke volume that is ejected by the heart with each contraction. Heart failure generally is due to any structural or functional disorder that prevents the ventricle from filling with blood or ejecting the blood, resulting in decreased cardiac output. In other words, a patient has heart failure if either inadequate amount of blood can enter the heart for movement through the body with contractions, or if the heart as a pump is too weak to move the blood through the system. There are some other causes of heart failure which fall under the functional category, such as anemia, where the number of red blood cells or the amount of hemoglobin in the blood to carry oxygen to the tissue is low, and the heart tries to accommodate by having larger stroke volumes or increased heart rate or both, but there's functional heart failure because the amount of hemoglobin in the system is inadequate to carry the oxygen or the needed amount of oxygen out and through the system. So other than saying that, I'm not going to really talk anymore about those other causes of functional heart failure that we may encounter. So if we look at heart failure, we can look at it from the perspective of cardiac function or from the perspective of cardiac anatomy. So we look at it from the perspective of cardiac function. We look at it from the perspective of, is it a heart failure issue related to systolic function or diastolic function? From the perspective of systolic heart failure, that is seen when the heart or one or both of the ventricles have impaired contractility. The heart simply doesn't have the strength as a pump to move blood through the heart and into the system as required. Diastolic heart failure, however, is not a matter of muscle strength, but more a matter that the heart as a muscle doesn't relax adequately, so there is inadequate filling of the heart during diastole, and so when the heart does contract, there is less blood moved through simply because there's less blood in the chambers of the heart at the time of contraction. If we look at heart failure as defined by cardiac anatomy, we can look at it from the perspective of right-sided heart failure and left-sided heart failure. In right-sided heart failure, the problem is the right ventricle is unable to maintain adequate cardiac output, and from the left-sided heart failure, it's the left ventricle is inadequate or cannot provide adequate cardiac output during contraction. We'll have some patients who have such severe cardiac disease that they actually have biventricular heart failure, where it's both an issue of the right side and the left side in terms of function and performance. So if we look at systolic heart failure, what could be causing it? So we generally see it as a perspective of either, or define it as either a problem related to previous cardiac ischemia, such as myocardial infarction, where there is muscle death, and that muscle turns into scar tissue, which does not contract and can become flabby and weak with time. Or patients could have non-ischemic systolic heart failure, where there's muscle damage to long-term disease such as high blood pressure or hypertension, which can result in left-sided heart failure. There could be pulmonary hypertension that you might see in someone with COPD, which results in right-sided heart failure. You can also have muscle damage as a consequence of a previous viral infection or chemotherapy. Also, within the world of systolic heart failure, there may be patients who have valvular heart disease, where because the valves aren't working properly, you can develop systolic heart failure and the muscle becomes weak and flabby. From the perspective of diastolic heart failure, these are cases where there is stiffening of the muscle doesn't fully relax, the muscle actually becomes thickened with time, and because it doesn't relax, the heart as a chamber is not able to fully or adequately fill with blood, so with each contraction, less blood is ejected from the heart, and therefore less available to provide oxygen and nutrition to the cells. Chronic hypertension is a common cause of diastolic heart failure, just like it could also cause systolic heart failure. And you could also have problems with the muscle itself, where there's deposition of protein in the muscle. An example would be amyloidosis, where there is a problem with protein metabolism. Abnormal proteins called amyloid are deposited in the tongue, the heart, or the kidneys, resulting in organ damage with organ impairment. For today's discussion, we're talking about heart failure. So amyloidosis can cause a stiff heart where the ventricle does not adequately relax during contraction, or during diastole, so that it cannot fully fill with blood. If we start looking at right-sided and left-sided heart failure from perspective of causes, and when you look at causes, it would include systolic or diastolic heart failure. Pulmonary hypertension is probably the most common cause of right-sided heart failure in our patient population. Pulmonary hypertension can be idiopathic or primary, meaning it's caused by a primary lung disease for reasons that are not really understood. You can also have pulmonary hypertension as a consequence of COPD. Right-sided heart failure secondary to COPD is called cor pulmonale. And for our patient population, COPD as a cause of right-sided heart failure is probably the most common cause. There are some patients with pulmonary hypertension due to pulmonary embolism. We can see that in an acute setting where the patient has an acute pulmonary embolism. There's a large clot burden to the lungs, which means there's dramatically increased resistance to blood flow through the lungs, and the right ventricle has to work very hard to move the blood around. This can cause an acute pulmonary hypertension and acute right-sided heart failure, but also some patients with severe pulmonary emboli or who've had multiple pulmonary emboli over the years can develop chronic pulmonary hypertension directly as a result of pulmonary emboli and develop a pulmonary hypertension and right-sided heart failure. We can also see right-sided heart failure in patients who have a right ventricular infarct, where they have an acute inferior MI due to occlusion of the right coronary artery. Sometimes cardiac valve disease can cause right-sided heart failure depending on which valve is affected. And patients who have severe left-sided heart failure can actually eventually develop right-sided heart failure as there's increased ongoing back pressure from the left ventricle through the lungs into the right ventricle. From the perspective of physical exam, what might you see in a patient with right-sided heart failure? Well, patients will typically have JVD. They may have peripheral edema. If their right-sided failure is hard enough, they can develop ascites or fluid in the abdominal cavity, as well as an enlarged liver. These patients may or may not be hypotensive depending on the severity of their illness, and they may or may not be hypoxic depending on the severity of the illness. From my perspective, if they have isolated right-sided heart failure and they're hypoxic, it's for reasons other than the right-sided heart failure by itself. It could be their underlying COPD or other chronic lung disease, or they could have something else going on, such as sepsis. The key finding in discriminating between right-sided and left-sided heart failure is auscultation of the chest and what the lung sounds are like. Patients with right-sided heart failure have no auscultative findings of pulmonary edema, so if you listen, they don't have RALs. If we get a chest x-ray, there's no evidence of pulmonary edema on the chest x-ray. Left-sided heart failure can also be looked at from the perspective of systolic and diastolic. Left-sided heart failure, the two most common causes are myocardial infarction and uncontrolled hypertension. Occasionally, valvular disease of the heart can cause right or left-sided heart failure, particularly patients with severe mitral regurgitation or aortic insufficiency, where the heart tries to pump out blood, but because the valves don't shut properly, the blood will promptly fall back into the ventricle. So the ejection fraction is less than ideal, and with ongoing time, the wear and tear and strain of the heart causes left-sided failure. We will occasionally see acute left-sided heart failure in patients who rupture one of the muscles that controls the heart valves, and we will sometimes see that associated with large anterior MIs. There are patients who receive chemotherapy for certain cancers. One of the chemotherapeutic agents, adriamycin in particular, is well known to cause cardiomyopathy and left-sided heart failure. Those patients typically will have a echocardiogram done before and after they receive the drug to see if there's any effect. And then on rare occasions, we'll see patients who've had previous viral infections of the heart muscle called myocarditis, and that myocarditis can result in systolic left-sided heart failure. If we look at these patients from the perspective of physical findings, the big discriminator between right-sided and left-sided heart failure is what is the lung exam like. So if the patient has JVD, peripheral edema, and on auscultation they have RALs over their lung fields, they probably have left-sided heart failure. We would expect that their chest x-ray also shows evidence of pulmonary edema. And these patients typically, they'll also have evidence of right-sided heart failure as well, with peripheral edema, neck vein distension. They may or may not have ascites and enlarged liver. So how do we treat heart failure? Well, from the perspective of EMS, our focus should be on the ABCs. We would like to provide supplemental oxygen as necessary to keep the O2 saturation 94% or better. Capnography is a good tool to evaluate adequacy of respirations, and if it's elevated, should prompt you to think about starting the patient on CPAP. If the patient appears like they are in dire straits, it may be necessary to intubate the patient. Over the years, we've seen a dramatic drop in the number of patients who require intubation for pulmonary edema when we are with the utilization of CPAP, or in the emergency department we use BiPAP. 12-lead ECG should be done on these patients if at all possible to get an idea of whether or not the patient is suffering an acute infarct on top of a chronic problem. Nitrates have become cornerstone of treatment for heart failure in addition to CPAP. So for us, either sublingual or topical nitrates should be administered to patients who are normotensive or hypertensive, particularly if they have evidence of left-sided heart failure. It's probably less necessary if the patient has evidence of isolated right-sided heart failure with clear lung fields and normal oxygenation and capnography. If the patient is hypotensive and you think they're in heart failure, you should initiate vasopressor use in the field. For us, at this time, it is epinephrine. When we see the patient in the emergency department, we may use dobutamine or dopamine for the patients in profound heart failure, but typically our first steps are to secure the airway and provide either PEEP through the endotracheal tube or CPAP or BiPAP via a mask. So what about Lasix and morphine? These have been one of our cornerstones of treatment in years past. Lasix is used as a diuretic, and morphine has been used because it helps calm patients down and causes some vasodilatation, which has been seen or thought to be helpful to the patient. Well, we have taken Lasix off the truck, and we did that a couple years ago. There have been some articles out there to suggest that Lasix in the field may be detrimental to some of our patients, there are patients out there who may appear to be in CHF, but they're not. It could be pneumonia or underlying COPD or asthma. There was a study published in 2015 that retrospectively looked at EMS patients brought to the hospital with a clinical impression of CHF and who received Lasix. They followed these patients through the emergency department course of treatment, and they found that about a third of the patients who were felt by EMS to be in heart failure were found to have an alternate diagnosis after they were thoroughly assessed in the emergency department. Those patients who received Lasix who didn't need it did not have any significant adverse effect, but it was felt that patients with symptoms suggesting of CHF could be managed with other interventions such as CPAP and nitrates and stabilized, brought to the emergency department where a decision could be made whether or not the patient truly needed Lasix or furosemide after a full assessment was completed in the emergency department. For most patients in acute pulmonary edema, the problem is not fluid overload, it's more fluid distribution. So think about the patients you see at 4 o'clock in the morning who wake up with acute heart failure. Those patients went to bed with the same volume of fluid in their body as they have at the time that you see them. They were not short of breath at the time they go to bed. But now at 4 o'clock in the morning they have evidence of pulmonary edema and heart failure. Those patients have a problem with fluid distribution, and for patients with that problem, CPAP and nitrates work better and are better for the patient than Lasix. How about for morphine? Well, morphine does cause vasodilatation. That's good. If we vasodilate a patient with morphine or nitrates, it reduces the preload, meaning there's less pressure to the heart from blood coming through the veins into the right heart, so that load and volume of fluid returning to the heart is reduced. And from the perspective of afterload, nitrates reduce the pressure against which the heart has to pump against with contractions. So it's better to have a pressure of 120 systolic than a pressure of 160, and nitrates help get that blood pressure down. Morphine causes vasodilatation, but it does so by releasing histamine. Histamine is the chemical that causes hives and skin rash and swelling of the face and lips and tongue as part of an allergic reaction. Histamine causes the same response, the same reaction, and vasodilatation causes fluid to leak out of vessels, and it has the potential to increase the amount of pulmonary edema a patient has if you give it to the patient. So there's more fluid in the lung alveoli due to that histamine release by morphine. Their studies have shown that morphine is associated with increased likelihood of a patient being intubated if they were given morphine for pulmonary edema, and studies have also shown that CPAP and nitrates work better than morphine. So the bottom line for morphine is it's bad. It shouldn't be used for patients in CHF. The American Heart Association has removed morphine from its guidelines for management of CHF. Keep in mind, if you have a patient who has a need for a narcotic in the field because of a pain issue, fentanyl can be used even if the patient's in heart failure. Fentanyl has the potential to increase their blood pressure a little bit, but it generally will not aggravate the patient's pulmonary edema. So if the patient needs a narcotic in the field for pain control and also happens to have CHF at the same time, you can use fentanyl. How about dialysis patients? Well, dialysis patients who develop acute CHF or pulmonary edema, they require dialysis. But we can temporize as well in the field as we can in the emergency department with oxygen, CPAP, and nitrates. So the treatment in the field is very similar to what we do in the emergency department. If you have a dialysis patient who develops acute pulmonary edema, treat them with oxygen, CPAP if indicated, intubate if indicated, and treat the patient with nitrates if their pressure is adequate. So that's the end of our discussion today on CHF patients. Next month, our topic will be novel psychoactive drugs. There'll be a review of the British Medical Journal article on novel psychoactive drugs that was distributed to Workplace a month or two ago. And we'll go through the 4 different classes that are identified in the article.